Let me know when you want us to start.
I think we're just waiting for Marty.
Marty's on.
Good morning.
Can you hear me? It's ringing.
After we've overcome some technical glitches, this morning is a little bit cloudy, rainy day, April 30th. Hopefully May Day tomorrow's. We're moving into new phase of our COVID presentation. Hopefully we'll be able to intersperse additional ones, such as we're going to hear this morning, interspersed with the formal presentation, some of the research that's call on some of the people for the coming days to potentially share with us some of the work that they've been doing, whether it be work in progress or papers which have been submitted. I think it's very nice to know the work that's coming out of Sinai, not just when you read it, but even as an opportunity potentially to work with those people and collaborate, which is very nice. Tomorrow, Dr. Olin is going to give a presentation on vascular disease, vascular biology, not necessarily COVID related. For next week, May 5th is the cardiac cath lab. May 6th, we have another panel discussion on the response to the pandemic. 7th is non-invasive cardiology. On Friday, tomorrow with COVID patients, cardiography, Dr. Croft. So I'm going to give the screen over to Dr. Reddy to introduce this morning's presentation. Dr. Reddy.
We need everybody else on mute, though.
Right. If everyone would just stand by a moment, I'm going to mute everybody if I can, and then I'm going to unmute Vivek and Marty and so forth. So let me see if that works. Give me a moment, please. Vivek, you're logged in as yourself. Hang on one second. And who's the presenter? Mahmoud?
Yeah.
Very good. Hang on one second. Hang on. Okay, 1 second. Unmute here.
I think we're good actually now.
Okay.
Great. Thanks a lot, Eric, and thanks, Marty. So today we're going to have two presentations by two of the electrophysiology fellows. Mahmoud and Mohit are both going to present. Mahmoud's going to present two interesting electrophysiology type cases who are COVID patients. And then Mahmoud will take that and expand a little bit to some of the work that the other electrophysiology and cardiology fellows did, an analysis of malignant arrhythmias in COVID patients. So with that, Mahmoud, why don't you start off?
Okay, so I have two cases. The first is it's a case of presumed plaquenil azithromycin-induced long QT, and the second case is a complete heart block in a young guy with presumed fulminant myocarditis. So, sorry, let me just minimize this. So the first case is a 39-year-old woman with autoimmune hepatitis who underwent a liver transplant in 2009 and unfortunately complicated by recurrent autoimmune hepatitis. She has obesity with a BMI of 31.8. Her last echocardiogram from 2009 at time of transplant showed a normal ejection fraction with mild concentric LVH and normal RV function. She presented on March 28th with cough, short of breath, malaise, fever, and diarrhea for 1 week. She found to be hypoxemic to the 70s in room air and tachypnic to the 60s. Her saturations improved only partially, even with non-rebreather, so she needed to be intubated. This was complicated by right pneumothorax, and initially it was felt to be small enough and that she doesn't require a pigtail, though later on this was attempted. She was COVID positive. She was found to have severe COVID with end organ damage based on needing ventilation and needing pressors. Once she was intubated, she required moderate dose of levofed. She was started on day 1 on Plaquenil, the 400 BID, then 400 daily azithromycin. She was treated for potential secondary infection with vancomycin, cefepime, caspofungin, as well as the steroid for shock. Her admission was complicated by septic shock and acute kidney injury. Liver transplant team was consulted, and they recommended to lower the Prograf and to hold Excelsiv, giving the acute infection, and that she's already on steroid. She was started on CRRT on day 2, like on the 29th, and her respiratory status worsened, and she needed to be proned. The team attempted to do an echocardiogram, but the images were technically difficult, and the study was non-diagnostic. On the 30th, she continued to worsen and require multiple pressors. She was seen by the ECMO service and was felt to be not an ECMO candidate, giving multi-organ failure, refractory metabolic acidosis despite dialysis. On the 31st, unfortunately, her pneumothorax worsened. ICU team attempted a chest tube, but that failed, and she expired from pulseless electrical activity on the same day. Her white cell count on admission was 22 and increased to 36 the day before death. She had high neutrophil count with low lymphocyte, and her interleukin-6 was also elevated. Her CRP was 46 on admission and went up to 72 on day 2. Her potassium was normal on admission, slightly increased to 5.5, and she had one measurement that was at 2.7 few hours before her demise. Creatinine on admission was 2.5, increased to 4.7, and she was started on dialysis then. Her D-dimer was 8.6 and was above 20 on the 30th. Her troponin was mildly elevated on admission, but increased to 2.1 on the 29th and started to go down actually before death to 1.5. This is her chest x-ray with ARDS and a small pneumothorax here. This is her admission chest x-ray. Her initial ECG shows QTC of 410. So this is on presentation. Day 0 on Plaquenil and azithromycin. There was no other long QT medications started on presentation. As you can see, she had sinus tachycardia, but otherwise unremarkable. Obviously, she also has the left axis deviation. Day 1 on the 29th, and after like 2 doses of Plaquenil and 1 of azithromycin, her QTC was 491. Potassium remained normal at that time, and she started to show some possible like T-wave inversions here. The night on that day, her QTC continued to lengthen at 540 with more pronounced lateral T-wave inversion. Her troponin at this time was higher at 2.13, but potassium was otherwise low. We don't have an ECG on the 30th, but we have one on the 31st in the morning, and actually we have 2 that I'll show. This is at 4:01 a.m., and I presume it was done because of this rhythm. In close inspection, I believe it's probably AIVR with retrograde VA conduction that you can see sometimes here. A few minutes later, on the same day at 4:04, you can see the QTC is much, much longer here, probably more than 600 milliseconds. Her potassium was still normal at that time. Unfortunately, she died from pulseless electrical activity, and this is her telemetry just before death. This patient underwent an autopsy, and at this time I only can see anatomical pathology, but not histology yet. Cardiomegaly noted with a 465 gram. Reference range is 200 to 280. There was a LV hypertrophy as well. There is focal LV subendocardial hemorrhage noted, and there is congestion in the lung with possible consolidation. The second case is going to show an AV block in a young patient who unfortunately also died. So this is a 29.
Actually, sorry, but do you want to talk about this first case, or do you want to go through both of them first?
I was going to go through the second case and then present on the Plaquenil UTs after, as well as the second case. So this is a 29-year-old male with no known previous medical history. He presented to Metropolitan Hospital on the 25th with respiratory symptoms and was found to have COVID positive. He required intubation on presentation and low pressure support. They did do a bedside echo then, which showed mild LV dysfunction and dilated left atrium. His initial troponin there was 1.4 and trended down. He started to improve. He was treated with azithromycin, Plaquenil, as well as steroid. Unfortunately, 3 days later, he suddenly had acute hemodynamic compromise requiring maximum pressors and remained hypotensive with high lactate despite that. His pH was 6.8 and creatinine up to 3. They consulted Sinai for consideration of mechanical support. After consultation, he was given bicarb and calcium and transferred to Sinai main campus. At that time, he had a repeated echocardiogram at the Metropolitan Hospital that showed severe biventricular dysfunction, which was new compared to 3 days from admission. His pH improved to 7.13 after repeated bicarbs. Unfortunately, on presentation, his systolic blood pressure was in the 60s despite maximum pressors with a very low pH. A full echocardiogram performed at Sinai that showed ejection fraction of 8% with severe RV dysfunction as well, and moderate mitral regurgitation. Given refractory acidemia and multi-organ failure, it was felt that ECMO will be futile and was not attempted. His white cell count were also elevated. These are labs at our hospital. We don't have labs on his presentation to the Metropolitan Hospital, but basically shows increased creatinine, ferritin, as well as high lactate and white cell count. D-dimer, interestingly, was not elevated here. Sorry, we have only one ECG for this patient, and I think you probably can appreciate that there is a sinus tachycardia going on with complete heart block, presumably junctional with the left bundle, the escape, but this is the only ECG we have. Interestingly, when you look at his telemetry, you can see here, so this ECG is from 1359. He died later that day. You can see here, sinus tachycardia with complete heart block. Again, sinus tachycardia with complete heart block, but probably different aberrancy. 8 minutes later, compared to this, you can see him actually conducting one-to-one with very pronounced ST depression. And here you can see the transition from one-to-one to complete heart block. A couple of hours later, he remained in complete heart block. And then later that day, he lost his sinus activity, which you can see here. There's no sinus activity, just ventricular escape, which unfortunately stopped after. And he died at 17:16. So I'll start by talking about Plaquenil cardiovascular effect. Most of these are actually done in the SLE era and for chronic use, but we can extrapolate some of them that could presumably be important for short-term use. So in short-term use, which is probably more important for us here because we're only using this for our protocol is like 5 days. Some protocols I've came across were like for 10 days. The most important one probably is long QT and potential risk for Torsad. There's also potential risk for increasing the digoxin level due to some drug-drug interactions. On long term, Plaquenil can lead to platelet inhibition, as well also the long QT. Interestingly, AV conduction abnormalities, mostly left anterior fascicular block, but also sometimes complete heart block, have been seen in chronic use, especially with higher doses. Some old reports also reported on decreased LV performance and heart failure, which recovered in half the patients after they stopped the Plaquenil. This is with like very long-term, like years of being on the drugs. As I say, there's like some conduction problems that have been seen also with chloroquine, and as well as Plaquenil. Atrial and ventricular arrhythmias have been also seen, and this could be due to accumulation of these drugs in the lysosomes, which increase the lysosomal pH, which is one of the mechanisms how it's presumably fighting the virus. The mechanism behind long QT is not well understood, and there's also reports of sinus bradycardia by affecting the Fanny channel on the sinus node. When you look at the credible meds, both chloroquine, hydroxychloroquine are listed as known risk, and they both have reported cases of cardiac arrest as well as Torsad. Azithromycin is kind of similar. One of the recent COVID papers tried to kind of summarize the factors that are associated with drug-induced arrhythmias. And those are well known to almost all of us, mainly advanced age and female gender, patient with previous heart failure or structural heart disease, ischemic heart disease, previous myocardial infarction or bradycardia can be at higher risk, as well as those with long QT syndrome. Electrolyte abnormalities like hypokalemia, magnesemia, or hypocalcemia can also increase the risk of Torsad, along with renal impairment and hepatic impairment. I came across this, which was published a few years ago. This is a risk path score. So in this study, basically they studied around 180 patients who were admitted, and they assessed their risk of developing significant long QT while in hospital. Most of these patients were treated with either fluoroquinolone, haloperidol, or I believe fluconazole. And they did ECGs on day 1 and then day 2 or 3. So they come up with this complex score. Many of these risk factors you probably kind of think of, but they kind of like gave them numbers and came up with a score of like, if you have 10 or more, this gives you a high sensitivity with high negative predictive value of having significant long QT. They define significant long QT here by more than 450 or 470, 450 in men and 470 in women. HRS put this document, I think around April 21st, so like almost a week ago now. And they commented on inpatient management and monitoring, as well as an outpatient. For the outpatient group, they basically said, we don't recommend using it. And if you really want to, then just kind of try to do an ECG if the patient is considered high risk. For the inpatients, they that need to be treated by hydroxychloroquine or chloroquine, they recommend to optimize the baseline QTC by minimizing QTC prolonging medications, stopping any other drugs that may cause drug-drug interactions, and also correcting the electrolytes. They recommend to get a 12-lead ECG and telemetry if possible in patients that are at high risk. And they basically say if the QTCs are less than 500 or even 550 in the presence of bundle branch block, those are considered low risk. And they say you can even just use like a single lead to monitor them to try to minimize exposure and use of PPEs. Interestingly, I came across this paper from Brazil, which tried to study chloroquine, and they had a kind of a dose that was recommended in their country. It was like 450 twice a day on day 1, and then 450 once a day of chloroquine. And they hypothesized that if you use higher dose, you may actually have better outcomes. So they initially aimed to enroll 440 patients, but the study was terminated earlier due to a trend toward worse outcomes in the high dose group. So they ended up studying 81 patients rather than 440. You can see here, they basically look, and in this particular study, they actually included all patients suspected for COVID. So anyone comes in with severe acute respiratory syndrome, basically high respiratory rate, low oxygenation in these days, and suspected to have COVID before even COVID was confirmed, have been included. The high dose group were older. They had more hypertension, more diabetes, and more heart disease. They also had more asthma and chronic kidney disease. The QTC interval was similar in both groups on presentation, with 422 milliseconds in the low dose group and 428 milliseconds in the high dose group. The high dose group were also sicker based on the quick sequential organ failure assessment. They actually found higher mortality in the high dose group, 39% versus 15%. When they corrected for age, this was not yet significant. This was not significant, but it remained significant in all the subgroups when you don't correct for age. Even though that the mortality was corrected when you correct for age, they thought there's enough trend here to terminate the study. They also found, sorry, I did not include that table here. They also found much longer QTs with higher dose. This is one of their supplement. They found higher prolongation on the QT, as well as higher incidence of VT. They don't really describe it if it's VT or Torsad, but it doesn't seem to have contributed to the increased mortality. This is their supplemental index, which basically show you that the time of the QTC prolongation or the VT and the time of death in those who died. And you can see there's except this particular case, there was like most of them, they were like days apart. So the VT did not directly cause the demise of these patients. Okay, a few slides on myocarditis or troponin leak in these patients.
Sorry, just one comment though, Mahmoud. On the previous slide, remember, I mean, I agree with you. This was not a very good manuscript, and there were a lot of missing details. But that was the day of the first prolonged QTC or VT, as they put. It's very possible they had multiple episodes and they died because of that. So we just don't even know why they died.
Correct. Yeah. I mean, okay. Yes, but in their discussion, they do say that the death was not arrhythmic in most of the patients. I can give you the exact number later on, but they do mention it.
Can I ask a question?
Yeah.
So if we always have to balance risk-benefit ratio, and there's obviously been a lot of questions about the efficacy of using hydrochloroquine alone or in combination. And that's still controversial. And a lot of patients have been getting it empirically as outpatients, which obviously, considering what we know is the cardiac risk, is disconcerting. But if you do take it, and if you're monitoring the patient in hospital, and you do see a prolonged QT, how quickly is it dose related, meaning that within 10 hours after the last dose, the QTC will correct? So is it just transient? If you're watching it carefully, you can avoid the potential long-term complications or the short-term arrhythmic risk?
So that is not specifically mentioned. One of these papers in their discussion mentioned that it is well known that Plaquenil has a very long half-life, and there is potential risk of long QT or even arrhythmias, even when these patients are discharged and when they completely recover from a lung perspective. So, and they do emphasize the importance of doing like what we're thinking of, like doing like a patch or some sort of like a home monitoring, because we don't know when these patients go home if they still have some risk of arrhythmia, either from the Plaquenil or if they had some sort of a myocarditis that manifests later on.
You may be coming into answering this next question, because as we see many of the patients coming in with a trope, CK is not as high, and obviously some with abnormal echo documentation as well. So is it a double hit, meaning that, you know, does the disease itself impact potentially the conduction system, either obviously on the EKG or saliently, and therefore they're a greater risk, those patients with a higher trope potentially, you know, giving them chloroquine, because not only is it myocardial, but maybe the conduction system itself is being affected, and now you're giving them a double hit by giving them a medication.
Yeah, I mean, presumably, theoretically, yes, especially if they end up with bradycardia. I didn't see comments on that. Just wanted to mention, I apologize, they didn't include the table of the exact QTC. So in the high dose group, QTC of more than 500 milliseconds seen in 19% and 11% in the low dose group. And VT was 2.7% in the high dose group and 0 in the low dose group.
I also just mentioned something on the first case that you had was a liver transplant patient.
Correct.
The whole idea of patients who are immunosuppressed, whether it be naturally immunosuppressed or pharmacologically, including patients with cardiac or liver transplant. There was a correspondence in the New England Journal of Medicine yesterday about immune-mediated inflammatory diseases, saying those patients were getting a small study, but basically they had patients hospitalized, not hospitalized, and they were saying, though their analysis was small, the incidence of hospitalization among patients with immune-mediated inflammatory disease was not greater. I don't know whether Dr. Niebart is on the line, but there's been speculation that being immunosuppressed may put you at greater risk, but you may be at lower risk potentially for the cytokine storm, which causes significant damage. I know Dr. Reddy had an anecdotal first line response when he was seeing patients, when he was covering the wards in patients who had transplant. And what did you think, Dr. Reddy, just on that handful? And if any of the heart failure people who are on the line can also talk about transplant patients, do you think they're at greater risk, lower risk, higher risk for complications, or lower risk for long-term complications?
Yeah, I mean, I'll just make a very brief comment. That I was surprised that there were patients I remember taking care of who I expected would do horribly with this disease, and yet didn't. On the other hand, you know, there are other patients like renal transplant patients who did present with severe COVID. So I think it's a complicated thing, and it may be not all immunocompromised is the same entity, right? So.
Any of the heart failure people on the phone? Okay, I'm sorry. Can you go ahead? This is an excellent presentation. Thank you.
Thank you.
Continue.
So,
sorry, let me just take one more comment, because I think your point, your question before, Marty, I just want to address this issue of QT prolongation in these patients with hydroxychloroquine. You know, with hydroxychloroquine if you just look at garden variety patients who receive it, the lupus and rheumatoid arthritis patients, they get started as outpatients all the time. I mean, that's the routine practice, and at least there haven't been a rash of reports of patients dying suddenly. But it may be, and we just don't know whether or not it's different in the COVID patients, potentially because of what you're looking at here, myocarditis, potentially because of interaction with other medications, including azithromycin. I don't know if you're going to talk about that, but that's been the real concern. And there is a dose-dependent phenomenon. You know, as Mahmoud said, in that Brazilian paper, with the lower dose of hydroxychloroquine, the QT prolongation rate was 11% compared to close to 20%. That 10, 11% was also seen in a manuscript that came from Northwell, where they were doing routine patches, so telemetry patches on patients. And again, they saw about 11% of patients who had QT prolongation with hydroxychloroquine. So I'm not sure that, I think it's still an open question as to how teratogenic the hydroxychloroquine is in this population, but clearly it can happen. I mean, you saw, 5 or 6% of patients had it with the higher dose of hydroxychloroquine.
Thank you. Please proceed.
So I'll try to talk a little bit about myocarditis and myocardial injury. So this came to light first when one of the papers from Wuhan documented a 17% level of elevated troponin, and 23% noted to have even some heart failure syndrome. Acute myocarditis have been reported in mostly case reports or case series. I'm going to try to focus on a couple of circulation papers that basically reviewed the whole topic and put possible mechanisms in view. Sorry. Here they compared this to SARS-1, which happened in 2002, which was another coronavirus. There's a study that did autopsies in patients with SARS-1 and found 35% of heart samples showed the presence of the viral RNA in the myocardium, which in turn was associated with reduced ACE2 protein expression or downregulation of the ACE2. Myocardial damage may be due to different mechanisms as well in coronaviruses. In the initial phase of the viral myocarditis, direct virus-mediated lysis of cardiomyocytes occurs. This is usually followed by robust T-cell response that can lead to further heart injury and ventricular dysfunction. In COVID-19, particular attention has been given to the role of ACE2, the binding receptor, or actually one of the two binding receptors of the COVID to the cardiac and to the lung cells. ACE2 is highly expressed in pericytes of the adult human heart, which indicate an intrinsic susceptibility of the cardiomyocytes to SARS-CoV infection. SARS-CoV-2 appears to not only gain initial entry through ACE2, but also to subsequently down-regulate the ACE2 expression, resulting in reduced the conversion of angiotensin 2 to angiotensin 1 up to 7. And I'm going to explain why is that important in the next slide. So I'm going to start by point 2. So in the healthy subjects, angiotensin 1 to 7 limits the synthesis of pro-inflammatory and pro-fibrotic cytokines. Thus, downregulation of the ACE2 by the SARS-CoV with a subsequent reduction in angiotensin 1 to 7 levels may magnify the cytokine storm, resulting in an overwhelming inflammatory response. Also, one of the mechanisms by which cytokine storms can occur is due to severe lung inflammation and impaired pulmonary gas exchange that upregulates the pro-inflammatory cytokines. In another study, troponin levels had a significant positive linear correlation with the plasma CRP levels, indicating that myocardial injury might be closely associated with inflammatory pathogenesis during the progress of the disease. In this paper, basically, they put all these different mechanisms. So cytokine release cytokine release syndrome can lead to all of them, but these other ones can happen on their own. So one of the mechanisms of high troponins or myocardial injury, if you will say that, is the ACE suppression and downregulation, as we explained, by leading to high angiotensin 1 and 7, which the downregulation of those enzymes basically allow for higher pro-inflammatory cytokines. And that lead to direct as well as indirect myocardial injury. There's also direct myocarditis, as seen by direct virus entry to the myocardial cells. And there's only one case report from Italy of endomyocardial biopsy that showed acute lymphocytic myocarditis in the literature. There's also risk of microangiopathy, and we all know now the increased prothrombotic states in the COVID patients. There's also risk of vasculitis-like mechanism. The fourth mechanism by which these patients may have a high troponin is myocardial infarctions, either type 1 or by type 2 or demand, especially in those with undiagnosed non-obstructive coronary artery disease at baseline. Obviously, the cytokine release syndrome can lead to the other ones.
Sorry, Mohit, just to interrupt you, I want to get a time check. We only have about 20 minutes left.
Yeah, so I have.
Make sure Mohit has enough time to.
So I'll have like a few more slides. And,
okay.
This is a patient. This is a paper in JCE that basically looked at cardiac complications and arrhythmias in the recent coronaviruses. This is the SARS, the MERS, and then H1N1 and the COVID. Interestingly, troponin elevation was almost not reported in any of these previous outbreaks. It's been just reported recently, and it ranges all the way between 12% up to 28%. One of these studies actually documented around 6% of malignant arrhythmias that diagnosed by any VT or any VF. Basically, they talk about mechanical injury, which could be either myocarditis, acute coronary syndrome, or decompensated heart failure. In terms of arrhythmias, these patients are at risk of tachy and bradyarrhythmias, as well as drug-induced prolonged in QT and sudden cardiac death. The mechanism of sudden cardiac death has not been well reported on. This is the last paper that I'm going to quickly discuss. This is another basically review paper in Circulation that tried to summarize the different cardiac complications in COVID era. They came up with a terminology called acute COVID cardiovascular syndrome, ACOV-CS. They discussed the risk of acute coronary syndrome, either with a STEMI or NSTEMI, with or without acute plaque rupture. They also talked about troponin elevation and demand ischemia. In terms of arrhythmias, they mentioned that there's atrial and ventricular arrhythmias as well as complete heart block, but they do mention, in this paper, they say that we're not aware of any reported cases of complete heart block that has not been otherwise explained. Patient heart failure can happen either with preserved ejection fraction or reduced ejection fraction. There are a couple of case reports of patients who had myopericarditis and having tamponade. And there's also a case report of severe myocarditis requiring VA ECMO that after treatment with IVIG recovered. And there's the thromboembolic complications that we have all seen. This is basically the same thing that they basically put it in different mechanisms in terms of the acute myocardial injury, including myocarditis, cytokine, as well as the stress cardiomyopathy. Mechanisms for acute myocardial injury range between hypoxemia, arrhythmias, viral myocarditis, cytokine release syndrome, as well as stress-induced cardiomyopathy, as well as microvascular injury. This is the last slide. Sorry, it's busy, but it's basically they propose this mechanism of triaging patients with COVID. So they say you first use your clinical judgment if you suspect acute COVID cardiovascular syndrome. If you do, you start with a troponin. If the troponin is normal, you don't need to do anything. You just monitor the patients, and you don't even need to repeat a troponin unless if you have clinical suspicion. If you have a high troponin, then you kind of look for clinical deterioration with hemodynamic instability, shock, or significant arrhythmias. If that's the case, then they strongly encourage people to enroll patients in clinical trials. And if that's not available, then you can use any of the off-label use medications. They emphasize the importance of using a focused bedside ultrasound by the ICU team to minimize exposure to everyone. And only those with documented LV ejection fraction less than 50 and acute hemodynamic compromise, they can go to PA catheterization and or mechanical support. Two last points, they mentioned the importance of exercise restriction on discharge if myocarditis is actually diagnosed, because these patients are at increased risk of arrhythmias for 3 to 6 months till their myocarditis fully recovered. They mentioned the importance of initiation of guideline-directed medical therapy if heart failure with reduced ejection fraction actually documented, but they recommend to delay that for a later time, because these patients, even if they're discharged, they're at risk of hypotension from other reasons. So they say discharge them home and like see them in a couple of weeks. And if they still stable and with low ejection fraction, then you can start your beta blocker and ACE inhibitor. I'll stop here.
Okay, thanks, Mahmoud. So, as this crisis was going on and we saw hints of arrhythmias in these patients, and certainly there were reports, certainly from Wuhan and a few other places, of malignant arrhythmias, we decided to try to take a look at this a little bit more carefully. So why don't we stop sharing your screen, Mahmoud, and let's let Mohit share his screen and show us what is actually our data at Sinai, what the methodology used, and what we saw. So Mohit, you're muted. Okay, good.
Yeah. Can you?
Now you have to hit share your screen and then pick which screen.
Yeah.
Is Dr. Lala on the line?
Okay.
Dr. Pinney?
Okay, we only have about 15 minutes, Mohit, so let's
Yeah, can you see?
get right into it. We have enough background.
Okay. So so this is going to be a quick presentation about the research that was conducted at Mount Sinai Hospital. I just have 9 slides, so it should be pretty quick. So Mahmoud did most of the background. So just quickly, as we know, coronavirus is a pandemic and has affected over 3 million individuals worldwide and over 1 million in the United States. So prior studies have shown that the frequency of arrhythmias have ranged from 16 to 30% and were even higher to about 44 to 75% in the critically ill patients. One study had reported that the so-called malignant ventricular arrhythmias occurred in about 17% of COVID-19 patients and were more often seen in patients with abnormal troponin levels. So this basically prompted us to do the study because of the speculation that clinical deterioration and mortality in severe COVID was associated with acute malignant cardiac events, such as VTVF or myocardial infarction. So this study is obviously a single center retrospective study. The inclusion criteria consisted of patients over 18 years of age admitted to Mount Sinai Hospital between March 7th to April 12th, who at least received 24 hours of inpatient telemetry monitoring and reached a final disposition of either death or discharge. The exclusion criteria consisted of patients who remained hospitalized during that time, who were discharged but got readmitted during the study period. Actually, there was just one of them who was excluded, and pregnant women and children less than 18 years of age. The composite primary endpoint of the study was either VTVF, causing hemodynamic compromise or cardiac arrest, AV block, causing hemodynamic compromise or cardiac arrest, or acute ST elevation MI. So this is a consort diagram how the patients were enrolled into the study. Out of 1,354 medical records, which were looked into the Mount Sinai system, about 847 of them were either discharged or dead. out of which 47 patients were excluded because they were either not COVID positive, less than 18 years of age, or had repeat admission. So finally, we ended up with 800 patients, out of which 140 of those received telemetry monitoring during the hospital stay and met our inclusion criteria. And 660 of those did not have any tele and were excluded, out of which we actually analyzed 78 patients who died without tele as part of the supplement for this paper. So out of the 140 patients included, 88 of them were discharged and 52 of them died and were included in the primary endpoint analysis. So this is the baseline characteristics of the study. As you see, the patients the median age of the study population was 61, ranging from 48 to 74. The ones who died were obviously older compared to the ones who survived, 71 and 58 years. But otherwise, most of the baseline characteristics between the two groups were pretty equivalent, other than two comorbidities, such as obesity, which was much higher in the ones who died, about 48% compared to 31%, and chronic kidney disease, which was 25% compared to 10%. But otherwise, only 16% of the patients had no comorbidities, out of which 21% were discharged and 8% died. So otherwise, there was also no difference in any of the baseline medications between the two groups. When coming to the laboratory data, obviously the ones who died were sicker, so they had higher LDH on admission, higher creatinine on admission. D-dimer was significantly elevated on admission and the peak levels. The admission D-dimer in the ones who died was 2.4, while the ones who were discharged was 1.2. Similarly, the troponin levels were also elevated in the ones who died compared to the discharged. Interestingly, on admission, the ones who died, the baseline troponin level, the admission troponin level was 0.03, but the peak troponin level was significantly elevated between the two groups. The ones who died had a troponin level of 0.27, and the ones who got discharged only had a troponin level of 0.02. In addition, the BNP was also significantly elevated in the ones who died compared to the ones who were discharged. However, the baseline echocardiogram EFs were normal between the two groups. Now coming to the treatments and the complications between the two groups, the ones who died obviously were admitted, were sicker, so they had more ICU admissions. They had more days on the ventilator. They had more pressor requirements, and also had more antiarrhythmic requirement between both the groups. The ones who died had about 23% of them required some sort of in-hospital antiarrhythmics compared to only 4% who survived. In addition, the ones who died obviously had higher complications such as ARDS, myocardial injury, acute kidney injury requiring renal replacement therapy, shock, and obviously there were a lot of palliative cares in the ones who died. At least about 38% of them were converted to comfort care. So coming to the primary composite outcomes, which was cardiac arrest, 16 patients actually met the primary composite outcomes in the entire cohort, out of which 12 patients died and 4 patients actually survived, which was, and the p-value was statistically significant with the hazard ratio of 4.6, suggesting that the ones who died obviously had higher primary outcome events compared to the ones who survived. This was mainly driven by the VTVF events between both the groups, which was 11% in the ones who died compared to only 1% in the ones who survived. AV block and acute ST elevation MI were also numerically higher, but there was no statistically significant difference between both the groups. And all these events, which was VT and VF, occurred mostly in the setting of high pressure requirement, metabolic acidosis, electrolyte abnormalities, and severe hypoxia. But the AV block and ST elevations were rather independent events, and it didn't seem like they occurred in combination with these other issues. This is the EKG and the telemetry data between both the groups. The baseline and the follow-up EKGs were pretty similar between both the groups. the QT prolongation at discharge was seen in about of more than 50 milliseconds, was seen in 13% of the patients who died, and 7% those who survived. There was no significant difference between both the groups, but numerically, the ones who died had a slightly higher QTC prolongation than the ones who survived. Interestingly, the number of patients who had atrial arrhythmias were significantly higher than the ones who died. About 35% had atrial fibrillation or atrial flutter, compared to 11% those who survived. But otherwise, obviously, the ones who died had higher VTVF and PEA, which was the predominant arrhythmia, the cause of death in all these patients. So in conclusion, hospitalized COVID-19 patients who die experience malignant cardiac events more often than those surviving to discharge. However, these events represent only a minority of these deaths, and ventricular arrhythmias are mainly associated with metabolic derangement. Thank you.
Mohit, that was excellent. Can you just tell us a little bit about how you and your team went about doing it? Just, explain to us the precision of your work. How do you adjudicate cause of death, things like that?
So obviously this was required a lot of manpower, and there was extensive coordination between all the cardiology fellows and EP fellows and everyone. So we went about, we actually started looking at all the discharges and the deaths. We actually initially got a list of the patients who were actually admitted to the hospital with COVID-19. And then we started screening those patients to look for the ones who died or got discharged. So that involved a lot of work, because for every 10 patients who were discharged, only 1 or 2 of them met our criteria. And then we subsequently had to do an extensive chart review, collecting all these variables, and also looking at bed master for every single day, looking for any arrhythmias that occurred during the hospital course. So eventually, out of all the patients screened, only 140, at least 1,000 patients were screened before we got to this number of 140 patients.
It was a tremendous amount of work. So how did you adjudicate whether the atrial or ventricular arrhythmia was caused by the COVID hypoxia, and the patients didn't die from the arrhythmia primarily, but it was the common end rhythm, but not necessarily causative? How did you determine that? Because that seems to be a major finding of your paper.
Right, because most of these patients, these arrhythmias were terminal events. The VT and VF were terminal events in most of these patients. And more importantly, I mean, there were no episodes of non-sustained VT or any other or significant number of PVCs that occurred before or a few days prior to these events. So, and these events occurred in patients who were either converted to palliative care or requiring high pressor support or severe metabolic acidosis, ARDS, and electrolyte abnormalities. So taking everything into consideration, we adjudicated all these events to be rather an epiphenomenon rather than a primary cause of the death of these patients.
Mohit, do you want to comment on the morphology of the ventricular arrhythmias?
So all these arrhythmias, the ventricular arrhythmias, most of them were polymorphic. There was only one monomorphic VT that occurred in a patient with low EF, but everything else was very fast polymorphic. And all of these events occurred just an hour prior to the patient's death, and they were all terminal. There were no PVCs or any other non-sustained arrhythmias prior to these events.
Can you discuss, taking into context the previous presentation about the myocarditis, how did that interplay with causative for the arrhythmias? Were they just two independent features of these patients who passed away? Or do you think that there was a cause and relationship that because the troponin was elevated, they were therefore more susceptible to the arrhythmia?
I mean, it's obviously that it is obvious from our data that the patients with myocardial injury were the ones who had a higher propensity of dying during the hospital stay. At least 75% of the patients who died had some sort of myocardial injury, compared to only 30% of them who actually got discharged. So obviously there is an increased propensity of having ventricular arrhythmias in these patients with elevated troponin, but it doesn't seem like that's actually a cause of these arrhythmias. And it seems like obviously there's a higher risk, but it cannot completely rule out the fact that and say that this is not a cause from the inflammation. But it looks like, taking everything into consideration, this is a secondary phenomenon.
So Mohit, so from this, we sort of conclude, unlike the previous Wuhan papers, while there are some degree of ventricular arrhythmias, they don't really seem to be the primary cause of demise or worsening in these patients. Those seem to be secondary. But let me just ask you a general question. In the COVID patients, based on what you and the other fellows have seen, what do you think is going to be the role of either AV conduction block or atrial arrhythmias in terms of worsening in these patients?
I mean, this obviously, since there's a lot of inflammation, it is definitely possible that will drive most of these arrhythmias. No,
I'm asking the other question. What's the possibility that arrhythmias are worsening the COVID patient? So yes, the myocarditis may cause arrhythmias, but then how important are arrhythmias in these populations? What have you guys seen so far when you're reviewing all of these telemetry? That's the real question.
At least based on the tele, these atrial arrhythmias that we have seen are mostly occurring, just before the death in most of these patients. It doesn't seem like, this was, in a few patients, obviously there's new onset AFib and arrhythmias, which is probably driving things. But in most of these patients, this is happening just before they die. And it's likely an epiphenomenon rather than a cause.
Okay.
Can you glean any information from the non-hospitalized patients that you have implantable devices? Because we're seeing, obviously, the subset of patients with more severe COVID who are coming into the hospital, but there's a large population who stay at home, who may or may not have gotten hydrochloroquine at home. Is there any information from implanted devices, loop recorders, pacemakers, defibrillators? Is there a greater incidence of arrhythmias in these patients who are going home, not hospitalized? Is there any?
We just don't have. I'm not aware of any such data, Marty. I mean, it would be nice to get that information to know whether or not, because there are patients who die at home. I mean, that was one of the initial reasons we got interested in trying to understand arrhythmias in these COVID patients, because of these sort of incidental case reports of people dying suddenly from home. Now, it's possible, now that what we know a little bit more, that many of these deaths probably were thrombotic deaths, right? Whether acute strokes or pulmonary emboli. But again, I'm not aware of data. There is, Northwell they published some of this already. They started very early with the policy of putting monitors on everyone who came in with COVID, so slapping those monitors. So at some point, maybe we'll see something from their data, but at least from the data that we've seen so far in the inpatients, we have not seen anything striking from an arrhythmic perspective.
So if you look at all of the patients, that your team, Dr. Miller, have implanted, defibrillators, right? If the incident of arrhythmia, ventricular arrhythmia, was happening at home, you'd expect to see an increased incident of devices firing, right?
No, it's a great question. Actually, Mark Miller was we were talking about potentially looking at this, but at least anecdotally, I don't think we've seen much. I mean, we were expecting a bunch of people to call in with events, and that is anecdotally not what we've seen. And it may be related to the fact that the individuals who are potentially at the highest risk, those with cardiovascular conditions, who have these devices, they may be the ones who are best sequestering themselves, for all we know. you know? So it's hard to really, number one, we don't see a flurry. Number two, I can't prove yet that the rate is lower, but if it is, my guess is it's related to perhaps less activity and being more careful with what they're doing.
So I think both of these presentations have been excellent, and I think Mohit and your team deserve tremendous credit. This took a lot of time and effort in going through the charts that carefully. You know, we're seeing a lot of publications with big data, which isn't necessarily good information because it's just, again, large numbers, but the detail in which you went through the charts is really remarkable. So I want to congratulate you and your team for it. Can I open up for questions in the few minutes that we have remaining? People can turn on their, unmute their speakers. Dr. Halpern, Dr. Fuster, if you're on the line, any questions?
No, nothing from me. I just want to congratulate you. This is really terrific information. I too have heard informally that the incidence of post-discharge documented arrhythmias in the monitoring studies that I've seen is quite low. But again, we need to wait to see what more information will reveal.
Thank you. Any additional questions? Again, thank you very much. This was a really great presentation. We'd like to hear more from the arrhythmia team in the coming weeks. So thank you again very much. Congratulate you and your team for putting so much time and effort to a very well done study. What we're doing is recording these studies. We'll have both the audio and video so that it is publicly available. We'll let you know. We're trying to put it in CC Live cases in a special COVID section. We'll give you more details. But again, thank you very much. Have a great day. Be well. Be safe. Thank you.